topic of my presentation today will be closing gaps for migrants and people who inject drug. It's divided in two parts. So we'll start with migrants and then go to people using drug. So we talk today a little bit about the gaps and advantages and disadvantages in the treatment of this patient. I mean, it's especially the way to close these gaps. So what is the way to help our patients? So my disclosure. The question why is treatment of HIV and hepatitis in a group of migrants is challenging. Because of different problems, as everybody who here in this room who treat patients, who see patients every day, have a lot of migrants in a patient group. So it's know that the patient have a lot of problems. They have a limited access to healthcare system. It depends upon country, but sometimes it's no health insurance, it's no money. For example, to pay for medication, to pay for lab tests, to find appropriate insurance, to find social worker, it is language. It's communication difficulties, because if you have a patient with HIV and hepatitis or STI and somebody bring translator with you to talk about some sensitive things, it's difficult. It's of course stigma, discrimination. People come from country, probably they are HIV or hepatitis is a big stigma to countries. It's not so big stigma on the opposite day, so it's difficult. There's some social economic factors, structure factors, and forward. This is some data because of late HIV diagnosis for migrants versus non-migrants in European countries. And you see that people here on this graph divided on different region of origin, and I see that people come from not Western European countries to have the higher proportion of new diagnosed HIV infection with CD4 count below 200, for example. So you see that it's more problematic patients, sometimes more difficult patients for treatment. If you look for 95 cascades, what is a big challenge is there? The first 95, the migrants having a higher risk acquiring HIV infection. They're coming from countries with a higher HIV prevalence. We have experience with delayed HIV diagnosis because of testing. In migrants are low compared to people from country. The second 95, the linkage to care, it's not optimal normally because of different barriers like political barriers, community barriers, translation. And the third 95 is probably some issues with compliance because the migrants have so-called double stigma. They are migrants and then HIV positive or have hepatitis, which is a big problem. That is, if you divide at different levels, there are all these barriers. It should be probably some starting with the patient level. It's about knowledge and awareness about the disease. In a community level, what is acceptance? It's my community. What about my religion? Would I get support from my family? At some organizational economic levels like capacity, resources, and of course language barriers. It's today it's a little bit easy to solve because we all have DeepL and Google Translator and whatever, all these programs, but it's still not a normal communication. We have put everything on tablets. I had a situation last week with a new diagnosed patient with hepatitis B coming from Afghanistan. And this woman, they could not understand me at all. And I had nobody who speaks Pashto or other languages coming from Afghanistan. So, and I tried with a Google Translator and I put a lot of in text and they show me she's analphabet. She could not read. So, and then she called her daughter and telephone, and her daughter was in a school, and her daughter tried to translate, and her daughter was 12 years old, and tried to translate, what's hepatitis B, what is the plan for treatment, so it's difficult. What a solution. The ECDC and WHO advise against mandatory testing for migrants because it's stigmatizing, but they recommend to test migrants from the countries with higher prevalence, and at least offer a test with high HIV prevalence, more than 1%, and it should be done in a special way, as a free of charge, of course, and it should be done on a special sensitive level to explain what happens if results for example, positive or positive, and of course it's even in Germany sometimes it happens that, I mean, it's a country with a lot of money in health system, of course, but it sometimes happens that people come to a doctor and say, I would like to be tested for HIV, and ask why you would like to be tested. Have you risk? Otherwise you need to pay 20 euros or something like that. It's a big barrier, and it's not good. And we need to implement some other strategies probably to treat patients to improve treatment result. Talk already a lot about war in Ukraine, started 2022, and we have in European Union, we have a lot of people come from Ukraine now, not only in Germany, but also especially in Eastern European countries, Central European countries, especially in Poland, that I have some data from Poland later. If we look for comparing a cascade of HIV cascade in Ukraine, comparing with European Union, we see that it's not bad in this. We should not forget we're talking about countries completely in war. It is still talking about new diagnosed patient, new treated patient. But it's still lower if we compare with Western European countries for all the part of cascade. And think about that because we have some new patients come from Ukraine with HIV and with hepatitis. It's the last publication from Milosh and all other co-authors about patients or people with HIV from Ukraine in European countries, and you see if you look, for example, anyway, if you look for Poland with its red color there, you see that 17% of all HIV population in Poland now Ukrainian people, which is actually something very rare in Europe. So you have the 17% new migrants in the country, which added to existing population of HIV positive people. In Germany, it's about 1.6%. In other countries, a little bit less, but it's still high. There's some pictures that I put from Miloš Paševsky's presentation on AIDS conference, and from the presentation, it is just show the migration from, and in the left part you see the migration from Ukraine in different ways to direction Europe, and in different countries, especially in Poland, Czech Republic, Germany, Romania, Moldova, and other countries. And it's interesting, we talked yesterday already about it, about some new genotypes that you'll see in Europe. So for example, genotype A6 and the movement of genotype A6 from, especially from eastern part of Ukraine. Not forget the war started not 2022 but 2014, and there are a lot of migration in Ukraine already from the eastern part of Ukraine, which now it's part of this war. It's Donbass, it's Lugansk. They're moving to the western part or central part of Ukraine, then moving to other countries, for example, to Poland, and we see the new genotypes, especially in Poland now with subtype A6, and we see a lot of A6 also in Germany, because we look for all our Ukrainian patients for the subtype, and it could be relevant for some new treatment regimens. This is just the data of a small trial, but it's only a trial that we were able to have in Germany. So we do a trial in all willing participating German centers. With 37 centers, it's called Orange Study, including 8 pediatric clinics, and we total got about 940 questionnaires about new Ukrainian patients, just to look what are the group of the patients we are dealing with. So we saw that most of them were undetectable, most of them got TLD as a one single tablet integrase-based regimen, so with below 50 copies, and most of them high compliant patients. But it's still treatment was modified in 70% cases, but it's not a completely modification of treatment because we don't have TLD. We need to switch either to Biktarvy or to Dovato or to tenofovir plus dolutegravir, which is pretty the same treatment, but it's available in Germany. What we could do to improve care and outcomes in our migrants. So we need to enhance communication in our clinics, use interpreters, translated materials, some other approaches which are adapted for our patient. We try to address stigma, to explain patient how it works in our country. Some Ukrainian patient asking me, for example, if they have some central registry for all patients, because they are really afraid coming to a new country to be registered as HIV positive. So I try to explain that we have no registers, everything very private, and stay everything here in the clinic. But it's not understandable for many people, and it caused some other misunderstandings. For example, patients prefer to go to Ukraine back to get their medication and then come back and not to ask them for medical insurance to pay for medication, which will be actually very easy because of the afraid of the situation. They have no idea how it works, how this healthcare system works, and we try to, or we need new healthcare models which are sensitive in case of migrants. So then I switch right now to completely other story to people who inject drugs, because it's another big group, especially in our clinic, which is difficult, but it's about 40% of all my patients with HIV and with hepatitis, and we do opioid substitution treatment as well in our clinic. So let's try to talk a few minutes about that. What are the challenges in HIV and hepatitis treatment among people who use drugs? And of course, we talk about low treatment compliance because of lifestyle, because of patterns of drug use. We're talking about limited access to healthcare systems. Some of people have no insurance, some have no financial resources to even just a very simple example. In Germany, we have all medication are free of charge if you have insurance, but you have a co-payment, which is normally free, 5-7 euro. That is not a lot, but even that is a lot of money for many people. So you prescribe medication, you prescribe antibiotic if you have some infection, and you are happy because you think you could help somebody. The people go to pharmacy, have no control about that, and they come 1 week later and you see no clinical improvement. And you ask the patient if he took medication, and he didn't, because he was ashamed to say they don't have €3 for the copayment. He took his prescription and go home and never took his antibiotic because of €3. It's just very simple thing, but we need to think about it as well. So it's even €3 could be something that's crucial in the treatment, for example. There's a legal insurance barrier because of criminalization of drug use, because of absence of information, how the system works. What is a place for my opioid substitution treatment? could I have opioid substitution treatment, if the police will be informed about it. So that's all this thing. It's even for people who are born in Germany, it's not really understandable, but for people who are coming from abroad, who don't speak language, it's a huge problem. We know some comorbidities are connected to opioid addicts, as of course HIV infection, of course hepatitis B and C, but it's actual sexual transmitted diseases because of sex work connected to drug use, which we see every day. It's other infectious diseases like osteomyelitis, like dermatitis, like some other infection, and of course all other non-communicable diseases which are you see. This is one trial that I find it just interesting, what presented Croy in 2024. It was a little bit about people who are HIV positive but have a bad social economic conditions. Some of them living on the street. And the people got standard of care treatment. If you are not adherent for more than 6 months, have a viral load, and they got first 24 weeks treatment with standard of care oral treatment, and then they switched either to long-acting treatment or stay on the same standard of care once daily probably treatment. And the results, well, then after in the third step, everybody was switched to long-acting carbapenem. The study was performed in US, that we see this 4 weeks or 1 month injection, but it's actually American type of use of carbapenem. They have in Europe every 2 months, and US they have two possibilities, either 1 monthly or every 2 months. You have two different types. We don't have it in Europe. And you see results, the regimen failure in a group of long-acting was low. So it means for the people who have problem to find a place to sleep or have no money for food or living on the street, the once injection for the period of time, 1 or 2 months, is easier than taking everyday tablets and look that you don't forget your tablets somewhere and somebody's stolen your tablets or whatever. So it works. And its problem is with label, because we could not prescribe and label long-acting for people who are not undetectable, but in that trial they gave them first oral treatment to go to undetection level and then switch, but it's some new trials show that also effective for the people who switch from a detectable level of HIV. It's even American guidelines was already changed in that view, so they not recommend, but they say it's possible to give somebody long-acting even if not undetectable. Unfortunately, we don't have such changes in European guidelines, so we say we stay in label, so we wait the people go on a detection level, and then we could switch. For hepatitis C treatment, we need to treat everybody. We talked a lot yesterday already about that. It is absolutely clear for everybody. There is no contraindication for hepatitis treatment for people using drug, never. So it's no data support to use some special screening before we start hepatitis C treatment to look if somebody drink alcohol or use drugs or whatever. It makes completely no sense because it creates additional barrier. It makes treatment preparation longer, and it's unnecessary because of costs. It excludes some people from treatment. It creates einfach the problem to treat patient, and it creates, of course, new problem with HCV transmission, because you have new people who get new HCV infection from the people who are not treated right now. So if you have HCV positive person who have HCV infection, it makes no sense to make additional diagnostic there, to look for fibroscan, to look for 3 times for ultrasound, to do special tests for that. It's absolutely not necessary. If you have a chance to treat patient right now, please do it. It's important. That it's a different way how we could reach our patient with our diagnostic, with treatment. It's not obviously clinics or practices. It could be drug and alcoholic clinics. It could be a sexual health clinic, pharmacies, mobile clinics, prisons. It's everywhere we could find hepatitis C patients, we could treat them. Sometimes it's something to do with regulation. For example, in Germany, it's not allowed to give HCV treatment for non-medical staff. So we need a doctor to prescribe HCV treatment, which cause actually that we lose more time to send patient to doctor, to make an appointment, to look for the insurance. So it should be as easy as possible if we would like to reach some results in HCV elimination, which is actually possible. There is some data that show that it's some concerns about people who using drugs that they get reinfected because they're still using drugs. It's true, but we see some correlation between opioid substitution treatment and not opioid substitution treatment in terms of reacquisition or reinfection with hepatitis C, so that people are in care or get appropriate opioid substitution treatment. They are the lower risk to get reinfected and compared to people who are using uncontrolled drugs outside on the street. And that I switch now to opioid substitution treatment, and something that happens there as well, because it's crucial for many patients. They see data that show that people who are on opioid treatment with buprenorphine have higher retention and better cascade in hepatitis C treatment, which is absolutely clear because they are under medical control, their behavior is clear because they got appropriate treatment. It is here, the more patients referred to HCV treatment, more got treatment, and more show better result in compared to people who are not in buprenorphine treatment. And it's something new that happens there. You talked yesterday already about some experience in Ukraine with Buvidal, which is one of the medication that it's pretty new in opioid substitution treatment. It's a small lipid molecule that's be injected subcutaneously, and you have very slow release of buprenorphine either for 1 week or even for 1 month. So you cover patient and you close receptors for 1 month without patient need to come to your clinic or to take your take home. It also works for people who are not eligible for take home, for example, have the risk behavior because of other drugs like cocaine or amphetamine. It's make no difference, because if you inject buprenorphine, you close receptors, and even patient use some other opioids at that time, it's probably less effective because receptors are blocked already and you have really stable level of medication. There is some data of comparing sublingual buprenorphine compared to once and weekly dosages. So you see of pharmacokinetic data that it's pretty the same, either take every day buprenorphine or you give injection for 1 week or for 1 month, and it works for many, many patients. So we have patients who are coming from a long distance to our practice, and it was not possible to give take home because we are so non-stable. It was risky, and we decided to use depot. It was perfect because patient come 1 monthly, get his depot. You see patient 1 a month, and it's possible at that time to prescribe HIV treatment or hepatitis treatment or whatever. That is one trial what conducted in a prison in Australia. So they compare conveniently, standard of care in opioid substitution treatment in many countries. Methadone compare to a depot buprenorphine, and they look for results, and they saw that their self-reported use of non-prescribed, illegal opiates was pretty good. You see reduction to 12% from the starting of treatment, and unfortunately only for buprenorphine patient, but it was pretty the same for methadone. But you have the methadone problem in a prison, especially because of deviation of methadone, because people try to put it somewhere to give other person to inject them and so on. And for injection, for this subcutaneous injection, it's no way for deviation at all because it's already in your body. Okay, so I think I'm actually ready because the improving care and outcomes in people who use a drug. So we need to expand more new treatment strategies like long-acting in HIV, probably sometimes in hepatitis, and also in opioid substitution treatment. We will try to combine HIV and hepatitis testing in one place. We try to support decriminalization and stigma reduction in this group of patients, and use, of course, outreach programs, social worker, peers, and everybody who could help us with all this patient. Thank you so much for your attention.